Thank you for the introduction. It's really wonderful to be, that's not what I wanted. It's great to be back at Hopkins, even virtually, and have the opportunity to share with you some of our work today that focuses on prostate cancer and prostate cancer disparities. So is everything showing correctly here?
Yes, it looks good.
All right, thank you. So I'll start today with just a brief overview of the epidemiology of prostate cancer and some of the disparities we see in prostate cancer incidence and mortality. From there, I'm going to go into a couple recently completed projects from our group that focused on variation in prostate tumor molecular subtypes across racial and ethnic groups. And then another project that focuses on the impact of guideline changes on prostate cancer screening rates, again, considering heterogeneity across racial and ethnic groups here in the United States. And then I'll finish with just a brief overview of a newly funded project by the DoD, in which we're trying to increase prostate cancer screening uptake within our cancer center catchment area. So prostate cancer is the most commonly diagnosed cancer among men in the US, with over 210,000 cases diagnosed annually. And the average man in the US has about a 1 in 9 chance of being diagnosed with prostate cancer over the course of his lifetime. However, a majority of the men who are diagnosed with prostate cancer will ultimately die from other causes. Most prostate cancers are diagnosed at a localized stage, and the 5-year survival for localized prostate cancer is around 97, 98%. That being said, there still is a considerable mortality burden linked to prostate cancer. There's over 30,000 deaths annually from prostate cancer in the US. And it's the second leading cause of cancer mortality among US men. So despite question or so despite the high burden of prostate cancer, we've unfortunately had somewhat limited success in identifying risk factors for prostate cancer. So this is sort of a composite summary of some of the evidence from the WCRF AICR continuous update project and recent reviews. There's really only 6 factors for which there's broad consensus of an effect on prostate cancer risk. They're shown in this table here on the left. Again, older age is linked to higher prostate cancer incidence. Men of African descent experience higher prostate cancer incidence. Family history, certain genetic germline variants, taller height, and then obesity is linked to the incidence of advanced prostate cancer. And looking across this list, you'll note that for the most part, these are not modifiable risk factors. There are some other modifiable risk factors that are potentially linked to prostate cancer incidence. They're shown in the table here on the right. But for these, the current state of the evidence is still limited, and further work is really needed to validate these findings. So we see tremendous variability in prostate cancer incidence and mortality across racial and ethnic groups here within the United States. Prostate cancer incidence rates are highest among Black men, with an incidence rate of about 175 cases per 100,000 person years. The next highest rates are among white men, followed by Hispanic men, Asian and Pacific Islanders, and then the lowest rates are among American Indian and Alaska Natives. And you can see that Black men have prostate cancer incidence rates that are about 1.7-fold higher than what we observe among white men, and about 3-fold higher than what we observe among Asian or Pacific Islander men. These differences are even greater when we look at prostate cancer mortality. Again, Black men have the highest prostate cancer mortality rates, with rates more than 2-fold higher than what we observe among white men and more than 4-fold higher than what we observe among Asian or Pacific Islanders. So these are amongst the largest disparities we see in cancer across all cancer sites across racial and ethnic groups. But if we look further earlier in the natural history of prostate cancer, we can actually see these differences emerge before we even get to clinically detected prostate cancer and prostate cancer mortality. So this is a summary of the literature, again, showing the prevalence ratios, comparing the prevalence of prostate cancer precursor lesion and latent prostate cancer among men of African descent versus men of European descent. And you can see that autopsy studies in which they've looked at the prostates of men who have died from causes other than prostate cancer have shown that there's about a 20 to 50% higher prevalence of HG-PIN, as well as latent prostate cancer within these prostates among men of African descent relative to men of European descent. However, when we look at clinically detected prostate cancer and prostate cancer mortality, this gap grows substantially. And this really highlights the importance of social factors, economic factors, behavioral and environmental factors, as well as factors that influence healthcare access in driving the disparities we see in prostate cancer incidence and prostate cancer mortality. And to really emphasize the importance of access to care as a factor driving the disparities we see in prostate cancer mortality, I want to highlight this recent study by Robert Dess and colleagues at the University of Michigan. And they looked at differences in prostate cancer survival between Black men and white men in 3 different settings. The first setting here was the SEER registry data. So this is the National Cancer Registry data for the United States. It captures cancer incident, or about 25 to 30% of all cancers diagnosed in the US. And you can see that in their age-adjusted model, following a diagnosis for prostate cancer, Black men had 30% higher prostate cancer-specific mortality rates relative to white men. On additional adjustment for stage, this attenuated to 1.17. And then in their fully adjusted model, which accounted for age, stage, other clinical and pathological characteristics, treatment, as well as some measures of socioeconomic status, this attenuated to 1.09, but remained statistically elevated. So there still was a residual disparity here. However, they looked in 2 other settings as well. So those are the VA system, so the Veterans Affairs system, and then they pooled some data from, I think, 4 radiotherapy trials for prostate cancer. And so the VA and these clinical trial populations are populations in which there should be equal access to care, as well as an equal standard of care, irrespective of race. And you'll see that when they looked in these equal care settings, there was no association between race and prostate cancer survival. And even suggestively in the RCT population, there was some suggestive evidence that perhaps even survival was improved among Black men relative to white men. So this, again, really accentuates the importance of access to care as a major driver of these outcome disparities. So if we try and look holistically at how the disparate outcomes in prostate cancer arise, I'm partial to this model that's been proposed by the NIH Centers for Population Health and Health Disparities, and they identify factors on 3 different levels. Starting at the most distal level, at a population level, we can think about the impact of things such as social conditions and policies. These include the aggregate effects of socioeconomic status, our policies, cultures, norms, discrimination, including structural racism. It also includes our institutional context, such as our healthcare system. We also have intermediate level determinants. These are factors that influence our social and or determine our social and physical context. These include our social capital, social cohesion, social support, social isolation, as well as the physical environment in which we reside. And then finally, we have individual level factors. These are the most proximal factors. These include individual demographic factors, individual risk behaviors, as well as biologic responses to other individual level or intermediate level factors. And then finally, individual level biologic or genetic pathways, including things like allostatic load or genetic ancestry. And it's important to recognize that there's interactions across all 3 of these levels, which contributes to the disparate health outcomes. So with this context in mind, I want to start today with a project that looks at variation prostate tumor molecular subtypes across groups defined by self-identified race. So just as we've had somewhat limited success in identifying risk factors for prostate cancer, we've had limited success in identifying clinically or etiologically relevant prostate tumor subtypes relative to some other cancer types. This does not reflect a lack of effort. There's been upwards of 15 to 20 publications that have proposed different subtyping schemes that the authors claim are the relevant schemes for prostate cancer. A major limitation of this work to date, though, is that almost all of this research has been done in populations of predominantly patients of European descent. And it's unclear, again, how transportable these subtype classifiers are when they are applied to more diverse patient populations. So the goal of this work was to take some of these subtype classifiers that have been proposed for prostate cancer in Eurocentric populations and apply them in more diverse patient populations and see whether some of the hypothesized properties of these subtype classifiers were retained in more diverse patient populations. So for this aim, we used a data set called the Decipher grid. So this is a large gene expression-based data set that arises through clinical use of the Decipher genomic test. The Decipher test is performed upon biopsy or upon radical prostatectomy. And In this test, they use about 20 genomic markers to produce a score that predicts the risk of metastasis. So this is helpful in guiding clinical decision-making. That being said, in addition to these 20 markers, they run a full microarray chip. So there's gene expression data for 40,000 probes. So we used data from the Decipher grid for 428 Black and 762 white prostate cancer patients. To this, we applied transcriptomic subtype classifiers that we identified from the literature. And then we compared the subtype frequencies by self-identified race. And then we looked at the association between the subtypes and this Decipher genomic risk score and saw whether these associations were heterogeneous by self-identified race. A limitation of the Decipher grid is that there are no clinical outcome data, so we can't actually look at overall survival or distant metastasis-free survival. So we elected to use this genomic risk score, which is a validated predictor of risk of metastasis, as a surrogate endpoint. So we did a search of the literature, again, sorted through about 15 to 20 different prostate cancer subtype classifiers that have been proposed. And we settled on implementing 5 different classifiers for which there was actually sufficient information to implement the classifier, and which we felt were representative of the spectrum of approaches that have been proposed. So the first subtype classifier by Zhang et al. Characterized tumors based on their luminal or basal lineage, with basal-like tumors considered to be a more aggressive phenotype. The Tomlin subtype classifiers are based on the presence or absence of 3 common genomic alterations within prostate cancer, those being gene fusions between the TMPRSS2 gene and the ERG gene. That's our ERG positive group. Gene fusions between TMPRSS2 and other ETS family genes besides ERG, overexpression of the gene SPINK1, and then a triple negative subtype, which is characterized by absence of these other 3 genomic alterations. The U and the Kamun subtypes were developed through pure agnostic clustering approaches. They were designed to be prognostic and identify higher or lower risk prostate tumors. The U subtypes in particular, they emphasized the discovery of this PCS1 subtype that was associated with a higher risk of metastasis. For the Kamun subtypes, they emphasized the discovery of this S2 subtype that was associated with a lower risk of recurrence. And finally, the last classifier was the Al-Shalalpa subtypes, and that was meant to identify this subset of neuroendocrine prostate cancers. So this is a unique histologic phenotype of prostate cancer that arises, in which histologically the prostate tumor kind of looks like a small cell lung tumor. This is a phenotype that usually emerges in a metastatic setting and is induced by androgen therapies, and it's almost always fatal. So first, we wanted to see how similarly did these 5 classifiers classify individual level tumors. So was there agreement between these classifiers and how they were classifying the tumors? And you can see from the heat map here, there were broadly 2 different clusters among the subtype classifiers. The first was the Kamun and the Tomlin subtypes, which had really strong agreement in their subtype calls. And these subtype classifiers were generally based on the presence or absence of ERG or ETS gene fusions. There was weaker agreement among the U, Al-Shalalpa, and Zhang subtypes. And these were characterized by androgen receptor activity in the tumor, as well as tumor luminal or basal lineage. We next looked at the distribution of these subtypes by self-identified race. So you can see from the mosaic plots here, the relative proportions of each of the tumor subtypes among white men and among Black men. There were significant differences in subtype frequency for 4 out of the 5 subtype classifiers. The lone subtype classifier for which there was no difference was the Zhang subtypes, where there were about 25 to 26% basal tumors among both white and Black men. For the Tomlin subtypes, we saw significant differences. You'll see that among white men, the ERG and the ETS positive tumors comprised about 2/3 of all tumors, while for Black men, more than half of the tumors were this triple negative subtype, and it was more frequent to see the SPINK1 overexpressed subtype. Around 18% of the tumors were on Black men. For the Kamun subtypes, there was a pretty balanced distribution of the S1, S2, and S3 subtypes among white men, but for Black men, about 3/4 of the tumors were this S3 subtype. Similarly, we saw enrichment of this PCS2 subtype in the tumors from white men, with comparative enrichment of the PCS1 and the PCS3 among Black men. And then finally, for the Al-Shal-Alpha subtypes, the neuroendocrine subtype was pretty rare among white and black men, but it was about twice as common among black men, about 5% relative to 2.5% of white men. And then finally, we looked at whether their association between the subtype and the genomic risk score varied by self-identified race. So the panel on the left here just shows you the distribution of the genomic risk score among black and among white men. A higher score here is indicative of a higher risk of metastasis. So you'll see that the median score among black men was a little higher than what we saw among white men. I'm only going to highlight two of the subtype classifiers here, the U and the Camun subtypes. And here, I'll start with the PCS2. You can see that there was no significant differences in the distributions here. For the PCS3, the distribution among black men was shifted upward a little bit relative to white men, but I really want to focus on this PCS1 subtype. So if you'll recall, this was the major conclusion of this paper, that they had found this high-risk PCS1 subtype. And if we look among white men, it does seem to be a higher risk subtype. So again, the median Decipher score in this PCS1 subtype is around 0.7. This is a pretty high score. Clinicians, clinically, this is indicative of a high risk of metastasis. And then comparatively for the PCS2 and the PCS3 subtypes, it's a much lower median score. But when we look among black men, really, there's no major differences in the distributions of these three subtypes in the genomic risk score across these three subtypes. So it's not readily clear that this subtype is actually maintaining its prognostic value when applied to a more diverse population. For the Camun subtypes, we see a similar phenomenon. Again, there's no major differences for the S1 or the S3 subtypes, but they had identified this low-risk S2 subtype. This, again, does seem to be the case when looking among white men, but for black men, there's really no discernible differences in at least the association with the genomic risk classifier. So overall, we found substantial heterogeneity in subtype distributions by self-identified race across most classifiers, in this case, 4 out of the 5. The subtypes also showed heterogeneous associations with the genomic risk score. An example of that would be that the S2 subtype that we just looked at appeared to be a low-risk subtype among white men only. Some limitations of this work. Again, we looked at the differences of these associations and the distributions by self-identified race. As we discussed earlier, right, this construct of race and differences by race can reflect many different mechanisms. So this can reflect differences in social, environmental, behavioral factors, as well as factors that are linked to genetic ancestry. And given the limitations of our data set, we cannot really establish what mechanisms might be driving these different apparent differences in tumor subtype distribution and perhaps tumor aggressiveness that appeared by race. Limitations, again, that we didn't have hard clinical endpoint data. So we used this Decipher genomic risk score as a surrogate. It may be an imperfect surrogate of the risk of metastasis. And finally, the Decipher grid arises through clinical use of the Decipher test. And this test is predominantly performed at academic medical centers like Cornell and Hopkins. So it's not, the patient population included here is not necessarily readily generalizable to the broader US population of prostate cancer patients. That being said, I think the differences here are notable, and this really highlights the importance of inclusion of underrepresented populations in prostate cancer research, and particularly within prostate cancer genomics research. As we develop precision oncology approaches such as subtypes, we need to make sure that they are applicable to everyone and that we're not applying things that are not transportable to certain patient populations. Otherwise, this really has the potential to exacerbate already existing disparities. From here, I want to switch gears a little bit and move up the cancer continuum and consider prostate cancer screening, and particularly looking at the impact of guideline changes on prostate cancer screening rates among racial and ethnic groups. So the panel on the left here shows prostate cancer incidence and mortality rates over time, again, from the SEER registry data. So again, our top curve here is the incidence rate among Black men, next the incidence rate among white men, mortality rate among Black men, and the mortality rate among white men. And again, I want to highlight a couple of things here. First, the disparities we see in prostate cancer incidence and mortality have been quite persistent over time. And second, I want to highlight the incidence curves here, and there's a very distinctive shape to the incidence curve for prostate cancer over time. We see this gradual increase in prostate cancer incidence from the mid-1970s until the late 80s, at which point there's this rapid spike in prostate cancer incidence. And this coincides with the introduction of prostate-specific antigen, PSA-based screening for prostate cancer. So this was introduced and widely used starting in 1989 in the United States. So PSA testing and screening using PSA has been highly controversial since its introduction. We can kind of see its benefits manifest in the mortality curves here, where mortality from prostate cancer has been decreasing throughout the PSA screening area. But there are harms associated with PSA-based screening as well. PSA-based screening can detect a lot of slow-growing indolent tumors that confer a very low risk of mortality. And traditionally, we've been very aggressive in treating these tumors. So men receive surgical interventions that can have associated complications such as risk of infection upon biopsy, or issues that impact quality of life, such as urinary incontinence or erectile dysfunction. So the relative benefits and harms of PSA testing has been controversial for a long time now. And the US Preventive Services Task Force throughout much of this period elected to not give a recommendation one way or the other about whether men should be screened for prostate cancer. So they gave a grade I inconclusive recommendation, citing a need for additional evidence about the relative merits and harms of prostate cancer screening. This evidence finally came in the late 2000s, around 2009, with the publication of two randomized studies. There was the PLCO trial within the United States and the ERSPC trial based in Europe. And collectively, these two trials, at least in these initial reports, did not show a conclusive reduction in prostate cancer mortality in their screening arms. And they did provide evidence of some of the harms that we discussed, including overdiagnosis of prostate cancer and overtreatment. So as a result, in May 2012, the US Preventive Services Task Force issued a grade D recommendation against routine screening for prostate cancer using PSA. So many studies have shown that in the aftermath of this 2012 recommendation, there have been declines in prostate cancer screening, but whether this effect was heterogeneous across racial and ethnic groups has not been largely studied. So to that end, we looked at differences, we looked at the impact of the 2012 recommendation on prostate cancer screening rates and stage-specific prostate cancer incidence by race and ethnicity. To look at trends in PSA testing, we used data from the Behavioral Risk Factor Surveillance System. As I think this group is very familiar, this is a large telephone survey coordinated by the CDC and conducted by state health departments, in which they've asked about prostate cancer screening behavior, essentially in the even year questionnaires. So we took the data from 2012, 2014, 2016, and 2018, and looked at prostate cancer screening rates among men ages 40 to 74 without a history of prostate cancer. And we selected this age range of 40 to 74, since this really represents the widest potential age range where people think that prostate cancer screening may be beneficial. So prostate cancer incidence is too low, below age 40 to merit screening. And then at age 75 and beyond, men are more likely to die from other causes than from prostate cancer. And then we looked at differences in stage-specific prostate cancer incidence using SEER registry data from 2004 to 2017, again, looking within the same age group of men ages 40 to 74. So here's what we found. So just to orient you to the plots here, our y-axis is the proportion of men who self-reported receiving a PSA test within the past year. And then we have the 4 surveys that we included. The dashed lines here are indicative of publication of draft recommendations by the US Preventive Services Task Force. So we can see that the 2012 recommendation was actually published in a draft form in late 2011. And then in 2017, the US Preventive Services Task Force published a new recommendation for prostate cancer screening. And this was a grade C recommendation, in which they recommended shared decision-making between men and their providers regarding prostate cancer screening for men ages 55 to 69. And that's the current recommendation that still stands today. So If we look back to 2012, we can see that there's considerable variability in prostate cancer screening rates across racial and ethnic groups within the US. First, I just want to highlight that the range here goes from about 18 to 32%. This is much lower than what we see for other cancer screening tests. If you look at guideline compliance for colonoscopy or mammography, you get upwards of 60 to 70% of the US population is compliant among those who are recommended to be screened. For prostate cancer, we're in sort of the 20s to 30s range. So there's much lower compliance for prostate cancer screening relative to other cancer screening modalities. We do see the highest prostate cancer screening rates among non-Hispanic white men, followed by non-Hispanic Black men, non-Hispanic American Indian Alaska Natives, Hispanic men, and then the lowest screening rates among non-Hispanic Asian or Pacific Islanders. You'll note that among all of these groups, there was a decline in screening from 2012 through 2018. The magnitude of this decline in absolute terms was highest among, or is greatest among non-Hispanic American Indian Alaska Natives and lowest among non-Hispanic Asian or Pacific Islanders. We also wanted to see whether any of these changes reflected differences in secular trends that influenced healthcare access and healthcare utilization. So we fit multivariable adjusted and survey weighted logistic regression models to estimate the annual change in the odds of undergoing screening. And we found that there was a greater rate of decline in the rate of screening among non-Hispanic Black men relative to non-Hispanic white men. So this odds ratio here would be interpreted as there's a 14% relative decline in undergoing PSA testing per year for non-Hispanic Black men, and that's greater than the 11% decline that we see among non-Hispanic white men. For the other groups, non-Hispanic Asian Pacific Islanders, Hispanic men, non-Hispanic American Indian Alaska Natives, there were no significant differences in the rate of decline relative to non-Hispanic white men. This is in a wide age range for prostate cancer screening. So we did stratified analyses by respondent age. So starting with the younger men, ages 40 to 54, we can see that actually within this group, non-Hispanic Black men had the highest screening rates, still at around 23% or so. And this isn't necessarily surprising, given the higher incidence of prostate cancer among Black men. There are some efforts to try and screen Black men at earlier ages relative to men of other races and ethnicities. We do see, again, declines in prostate cancer screening across every group. Again, the largest absolute decline was among non-Hispanic American Indian Alaska Natives, and the smallest decline among non-Hispanic Asian or Pacific Islanders. And here again, we see at least a suggestive difference that there's a faster rate of decline in screening among non-Hispanic Black men relative to non-Hispanic white men. When we look among men ages 55 to 69, these are the men who currently have the grade C recommendation from 2018. We can see, again, very large decreases in absolute terms in prostate cancer screening across the board, but there was really no significant differences in the rate of decline. So the larger rate of decline that we saw in the broader population of men ages 40 to 74 is really attributable to differences in the younger age bracket of men ages 40 to 54. So we should be concerned about the sharp decrease in screening, particularly among among younger non-Hispanic Black men. So we published this study last year, and later in 2021, the 2020 survey data was released for the BRFSS. So I just want to give you a quick peek at that. And you can see that overall, the proportion of men who self-reported receiving the PSA test within the past year declined by 1% from 2018 to 2020. Looking across racial and ethnic groups again, there's sort of anticipated trends for non-Hispanic white men, non-Hispanic Black men, and non-Hispanic American Indian Alaska Native of modest decline from 2018 to 2020. There are some unexpected trends, though, among Hispanic men and non-Hispanic Asian or Pacific Islanders. Again, among non-Hispanic Asian or Pacific Islanders, we actually saw an increase in screening. This could reflect the 2020 or the 2018 recommendation, but again, it's not really clear. And then among Hispanic men, we saw a very large drop-off in screening from 2018 to 2020. Again, not quite sure what's driving that. Of course, when looking at the 2020 data, we start to be concerned about the impact of COVID on cancer screening. Numerous studies published over the past couple of years have shown just that cancer screening rates have fallen off a cliff during the pandemic as hospitals and care settings, as well as individuals, have elected to defer some of these preventive services. But I would argue that the trends that we're seeing from the 2018 to the 2020 data are really a continuation of existing trends and don't quite reflect the impact of the pandemic quite yet. So this plot just shows the proportion of men who self-reported receiving a PSA test by month of survey response within 2020. Again, the time frame that these men are asked to reflect upon is of their screening within the past year. So if they're being interviewed in January 2020, they're being really asked about their cancer screening behavior in 2019. Thus, we wouldn't really expect to see any impact of the pandemic until later in 2020, when the pandemic starting in March enters the time frame within the question of the past 12 months. And here we don't really see much of a drop off until maybe December. So I would guess that this doesn't quite reflect the impact of the pandemic yet, but when we get the 2022 data, I expect to see a sharp drop off. So this was one piece, was looking at prostate cancer screening rates. The other piece of our study looked at the impact of the 2012 recommendation on stage-specific prostate cancer incidence. You can see that for localized prostate cancer, which is the majority of prostate cancer, about 75–80% of prostate cancer, the highest incidence rates for localized prostate cancer are around 2007. And at that point, rates were already starting to decline. But then using our join point analysis here, we can see that the rate of decline accelerated starting in 2011 across every group here. And this really coincides with the publication of the 2012 recommendation. So we see this 2012 recommendation does seem to reflect or lead to an acceleration in the decline of localized prostate cancer incidence. This continues throughout 2014, at which points rates have either stabilized or, in the case of non-Hispanic white and non-Hispanic Black men, seem to be creeping back up again. The right-hand panel here shows the incidence rate ratio using non-Hispanic white men as our reference group. You can see that from 2004 through 2011, non-Hispanic Black men had about 1.7-fold higher localized prostate cancer incidence. From 2011 to 2012, this disparity jumped to about 1.85, and that's more or less where it's remained since 2012. What's somewhat alarming, though, is that we see increases in the incidence of metastatic prostate cancer or distant prostate cancer. So again, localized prostate cancer is almost always not fatal. Metastatic prostate cancer is almost always fatal. So it's alarming to see this increase in metastatic prostate cancer incidence, which is present in every racial and ethnic group. Notably, though, our join points suggest that this trend began in 2010. So this predates the 2012 recommendation. So this may reflect the timing of the publication of those two randomized clinical trials I mentioned, the PLCO trial and the ERSPC trial. It may be possible that those trials received widespread attention when they were published, and that may have been enough to undermine some people's confidence in PSA-based screening that leads to an increase in metastatic cancer incidence. There may be other factors that are driving just the higher incidence of metastatic prostate cancer incidence as well, but we need to identify those. And then looking at our incidence rate ratios, you can see for non-Hispanic Black men in 2004 to 2008, this rate ratio was around 3.1. It has declined over this period to about 2.4 in 2017. For Hispanic men, we see that the rate ratio was around 1.5 and has declined all the way down to 1. So at least on a relative scale, these disparities are increasing, but this is really not a public health victory, and that the absolute rates themselves are increasing. So overall, we saw that PSA testing rates have steadily fallen since 2012 across all racial and ethnic groups within the US. And there was a greater rate of decrease among younger non-Hispanic Black men relative to non-Hispanic white men. The incidence of localized prostate cancer has continued to fall since 2012. And we see rising incidence of distant prostate cancer across all racial and ethnic populations. Some limitations of this work. This is using serial cross-sectional studies. So we have an ecological design here. We're unable to follow the same individuals longitudinally over time and see how this guideline change actually impacted decision-making regarding prostate cancer screening on an individual level. The BRFSS relies on self-report of PSA testing. The sensitivity and specificity of self-report of PSA are a bit worse than what we see for other cancer screening modalities. So people are able to more accurately report, say, colonoscopy or mammography relative to PSA testing. And similarly, there's a guideline change in 2018, and the impact of that guideline change may not have fully manifested yet. But the 2020 data suggests that it did not do much to increase at least uptake of prostate cancer screening. So what do these screening trends look like within the Meyer Cancer Center catchment area? Well, the Weill Cornell Medicine New York Presbyterian Meyer Cancer Center is located in the Upper East Side of Manhattan. We do have regional hospitals in Lower Manhattan, Brooklyn, and Queens. So we consider the catchment area of our cancer center to be all of Brooklyn, all of Queens, and then the lower 6 PUMAs. So PUMA is public use microdata area. So the lower 6 PUMAs of Manhattan, which comprises Lower Manhattan and Middle Manhattan, but not Upper Manhattan. So all told, there's about 5.5 to 6 million people residing within our catchment area. And we see prostate cancer incidence rates and mortality rates that are more or less in line with the national averages. Our incidence is a tad higher, while our mortality is a bit lower. What does prostate cancer screening look like within our catchment area? We don't have the best data. So again, these are data from the BRFSS from the 2018-2020 surveys, men ages 55 to 69. And you can see, looking at New York City relative to New York State and the US, that New York City is kind of right in line with the national average. Again, we already just looked at all this variation in prostate cancer screening rates nationally, but you can see that there's at least suggestively greater variation within New York City, with the caveat that we have a limited sample size here, and you'll see that some of these confidence intervals are quite wide. But there does seem to be a larger gap in screening between non-Hispanic white men and non-Hispanic Black men within New York City than what we see nationally. So it's a priority of our cancer center to try and increase uptake of cancer screening and prostate cancer screening within our catchment area. And to that end, we have a newly funded grant from the Department of Defense, in which we're going to try a novel approach to improving prostate cancer screening among African-American men. And there's really 2 unique aspects to this project. So the first is that we're going to employ a point of care PSA test. So traditionally, to get screened using PSA, men have to come into a healthcare facility. They have, undergo venipuncture, serum PSA draws, and then that PSA test gets reported back to them with all their other blood work a day or 2 later. So we're hoping that use of a point of care test will help reduce some of these barriers to screening and barriers to facilitating immediate follow-up care if needed. And then the other unique aspect of this project is that we plan to implement this not in a traditional healthcare setting, but rather in a community setting. And specifically, we plan to implement this within barbershops in Brooklyn. So we'll take our point of care test, implement this within barbershops, and we will have the barbers will actually be members of our research team. So they will be engaged as citizen scientists who are members of our research team and bring their experience as community members to our research team. So our project is led by Dr. David Nanis, who's the PI of this grant, and he's a urologic oncologist, but we have experts across many disciplines, including internal medicine, community outreach, urology, epidemiology, clinical chemistry and assay development, as well as biomedical engineering. And equally important in this, we've assembled a stakeholder advisory team that will work with us every step of the way. And this stakeholder advisory team is composed of Brooklyn-based prostate cancer survivors, healthcare providers, community organizers, and health communication experts. So the first 2 aims of our study really focus on the development and validation of the point of care test. In AIM-1, we'll optimize this test for quantification of total PSA in a finger prick collected whole blood sample. AIM-2 will be a small validation study, which we'll conduct here at the Prostate Cancer Clinic on the Upper East Side. And in this small validation study, we'll have about 50 men who are prostate cancer patients undergo the point of care PSA test, as well as the standard PSA test that they would receive in their normal follow-up. And we'll compare, we'll examine the correlation between the two PSA values. AIM-3 will then be taking the point of care PSA test and implementing this within the community setting of barbershops within Brooklyn. So how will this point of care PSA test actually work? Well, I think we've all kind of gotten used to these rapid COVID tests, so it's kind of a similar principle here. So the patient will be consented, will prick their finger, and then 1 drop of blood will be added to a lateral flow test strip. The blood will then flow along the strip, and it produces, the same 2 lines that we're always wary of seeing the T line appear on our test. But we can actually use a reader machine here that will calculate the relative abundance of the T line relative to the C line, the test relative to the control line. And using a standard curve, this machine can then actually back calculate the concentration of PSA. And for men with elevated PSI, we would then know to refer them for follow-up care. So again, we plan that our barbers who are acting as citizen scientists will actually be the ones implementing this intervention within their barber shops. So we plan to recruit 4 barbers, at least in our initial pilot study here, who will act as citizen scientists. They'll be paid for their work, and they'll be undergoing training to be citizen scientists using sort of this curriculum shown here on the right, which is adopted from the University of Florida citizen scientist curriculum. They'll undergo 15 hours of training in 3-hour blocks that focus on their role as citizen scientists, biomedical research, research ethics, what's the importance of developing an evidence base with regards to policies. There will be a module specifically on prostate cancer and prostate cancer screening, a module on how to motivate and engage members of their social networks, and then finally, a module on the importance of data and maintaining privacy and confidentiality. So at least in this initial grant, we're still in a pilot phase here. So our target enrollment is screening 100 men, ages 40 to 74 with no history of prostate cancer, using our point of care test. How we envision this unfolding is that barbers will engage their clients in a discussion regarding prostate cancer and the pros and cons of prostate cancer screening. Should the client then decide that he is interested in being screened, there will be a research nurse on site who will confirm participant eligibility, obtain written informed consent, and then perform the point of care PSA test. Given that this is a pilot study and given our timeline, we're not sure that the point of care PSA test will actually be CLIA certified by the time we're actually really ready to do our community intervention. So we're going to actually just obtain a blood spot as well. We'll take this back to the lab. It will be run on standard CLIA certified assays. And that's what will actually be reported back to the participants, at least at this pilot stage. Again, there's ethical considerations in reporting back a non-CLIA certified result to these men. So we're going to report back the lab PSA value. Participants will also complete a brief questionnaire after undergoing the point of care tests, provide information about demographics, socioeconomic status, their perceptions of cancer risk, cancer screening history, as well as whether they found the screening test itself to be acceptable. And then the following day, we'll report back the lab screening result to the participants, and we will facilitate whatever follow-up care is needed, including patient navigation services and assuring healthcare for men who may not have health insurance. So there's sort of 3 main endpoints of interest to this third aim of our grant. The first one is the acceptability of the point of care test. Our primary metric for this is the proportion of men who are approached to undergo testing, who are actually willing to undergo testing. And then we'll do some demographic comparisons of the men who are willing to participate and take the test versus those who are not, to see whether this is actually helping to capture men who might otherwise not be screened in a traditional healthcare setting. Since we have the point of care PSA test and the lab PSA test available for all these men, we'll again look at the validity of the point of care test and examine the correlation and the sensitivity and specificity of the point of care PSA test versus standard cut points against our gold standard lab PSA test. And then finally, we'll assess the feasibility of implementing this point of care test in barbershops specifically, and this will be assessed through structured discussions with the barbers at the end of the study. So I'll stop there, but I look forward to discussing, but I want to thank all my collaborators here at Weill Cornell and beyond, the participants in all these studies, the community stakeholders that help make massive contributions to this work, as well as the funders. Thank you for attention, and I'm happy to take some questions here.
All right, thank you, Dr. Kensler. That's great. Who would like to ask the first question?
Yeah, Dr. Grootman.
Hey, Kevin, how you doing? That was terrific. Actually, your point of care study is really fascinating, particularly given the centrality that the barbers and hairdressers, hair salons play. I mean, I guess not only in Brooklyn and Queens, but certainly here in Baltimore.
Yeah.
So it'll be very interesting to see how that plays out. I wanted to sort of step back into some old data and just to tease your brain about whether there's any updates, but sort of what was now the classic autopsy study from Detroit that showed that for every year of age in men, the if you will, the incidence of prostate cancer increases at roughly 1%, so that 50% of 50-year-olds, 60% and so on. And I was wondering, to your knowledge, has there been any update of those data? And are there any differences between Blacks, whites, Hispanics, and so on?
Yeah. So I guess going back to the first point about barbershops, again, I think, right, the barbershops are an established place where many people have particularly done health education interventions before. I think there's been limited actual interventions done in barbershops for where men actually receive health care. There are some studies that have shown, there's studies that have done screening for diabetes or hypertension control within that setting, but we do think that this is a unique aspect of our study. With regards to the autopsy studies, I think that a lot of this work has not really been updated since the 90s. So I'm not familiar with any studies that have come up in the last decade or two that show any differential trends. I, again, can't remember what the exact proportions are, but you do see that, a higher proportion of Black men have prostate cancer or latent prostate cancer at earlier ages relative to non-Hispanic or to white men and Asian or Pacific Islanders. So I want to say it's like 60% of men or something have it by age 60, but again, don't quote me on that. I'd have to go back to the original studies.
All right, thanks.
Right, Dr. Klingner.
Hi, Dr. Kensler. Thank you so much for that talk. It was great. I just had a question about, I do not prostate cancer research, but a lot of global oncology work, and just about kind of the cost of the point of care PSA test, because, if it could be used somewhere in sub-Saharan Africa, I don't know how expensive or inexpensive it is at this point.
Yeah, I'm not quite sure about the costs of it, but I know that it is made and developed with costs in mind. So our collaborators in biomedical engineering for this are at Cornell Ithaca, and Saurabh Mehta and David Erickson, and they really focus on bringing healthcare to low resource settings, particularly in sub-Saharan Africa. So I didn't mention this today, but if you look at the global incidence and mortality rates for prostate cancer incidence rates are highest in sub-Saharan Africa, in the Caribbean as well. And men there are largely unscreened. So many men just present with prostate cancers that are already metastatic. Screening in these settings would be tremendously helpful. So we do see applications of this test where it can help with screening in some of these lower resource environments.
Thank you.
Dr. Muniz, did you have a question?
No, I was great, Maestro. Beautifully done.
Well, thank you, Maestro.
So, Kevin, you mentioned very compelling what you talked about in terms of the risks associated with testing, and interesting to get the history behind it. I wasn't quite clear. Have there been improvements in the PSA testing since 2012?
So I'd say that the test itself is largely the same. There are some new variants on it, like a 4K score that incorporates PSA and other kallikrein markers, or the PCA3 test. I don't think that those have widespread use as of yet. I think where the major changes have actually come and have been in terms of how we treat prostate cancer. So it used to be that everyone who was diagnosed with prostate cancer, regardless of whether it was a low-grade prostate cancer or a high-grade prostate cancer, received a radical prostatectomy. We've moved on from that model. We recognize now that many prostate cancers confer a very low risk of actual death from prostate cancer. So we've seen rapid increase in methods such as active surveillance. And so in active surveillance, men don't actually receive a definitive treatment for their prostate cancer, at least initially. So they don't receive surgery, they don't receive radiation, and therefore they can avoid some of the side effects associated with those treatments. And so they just have, continuous monitoring of their cancer using PSA. We're starting to use MPMRI a lot more within prostate cancer, which again is a non-invasive way to just keep tabs on the prostate cancer. And if there do seem to be signs that, there's cancer progression, at that point we can intervene. But for many men, particularly at older ages, this is sufficient. And, so long as they're going in and they're monitoring their PSA over time, we can be pretty confident that they're not actually going to suffer any significant morbidity or risk of mortality from that cancer.
Yeah, thank you. Philip, did you have a question?
Yes. Thank you for your talk. It was really some interesting work, especially the study in the barbershop that you mentioned, described at the end. And I had a question about that. So with prostate cancer screening, there's this large component of shared decision making. And so moving from a setting in the clinic where it's a private conversation to a barbershop where it's not, I don't know the details, but it sounds like it's not. Do you expect things like interference? So if you have, and this could go either way. I mean, if someone says no, that may influence other men in their presence, or someone says yes, it might nudge them in that direction. And then sort of referencing some of the literature that you mentioned about prior, I know this is a pilot study, but some prior trials in barbershops have been cluster randomized for that reason. And so I guess just it's interesting how that implementation changes when you move out of the clinic. So I was wondering if you had any comments on that.
Yeah, I mean, I think those are great points. And obviously interference is an issue, and that, people are going to overhear conversations, and it's likely to be a larger group engaging in the conversation that will likely reach some broader consensus as a group rather than on an individual level. So I think, this is a pilot study. I think, the larger trial that we planned would be, it's hopefully the follow-up study that comes of this is cluster randomized, in particular for that reason. So yeah, I think that those are definitely issues that we are considering.
All right. Well, thank you so much, Kevin, for being on. Happy to share your email if anyone in the audience has more questions. But thank you so much for joining us, giving this great talk.
You can see it right there.
Oh, very good. Yes, thank you.
Great.
Thank you so much, and we'll see everyone next time. And Kevin, keep doing your great work. This is great.
Really great work.
Thank you, and great to see lots of friends and familiar faces here.
Yeah, Excellent.
some,
Thanks so much.
yeah.